Guest today. Pierre Elias is an assistant professor in the Division of Cardiology and Department of Biomedical Informatics at Columbia University, Irving Medical Center, where he practices as a general cardiologist. He's also the medical director for artificial intelligence at NewYork-Presbyterian. His research lab develops machine learning technologies for medical imaging to improve the detection and management of cardiovascular disease. He received his medical degree at Duke University School of Medicine. He completed his residency in internal medicine and fellowship in cardiovascular disease at NewYork-Presbyterian, Columbia University, Irving Medical Center through the clinician scientist pathway. He has been named a Stat News Wunderkind, highlighting 20 of the most innovative junior researchers in the country, and has received the Emerging Generation Award from the American Society of Clinical Investigation. He was previously a data scientist at Lumiata, helping develop Google's knowledge graph for health. I've had the pleasure of meeting Pierre for the last 2 years now through the work I do with the ACC Innovation Council. He's currently also on the leadership council for that and has steered a number of the artificial intelligence programming and thought leaders, providing subject matter expertise on artificial intelligence and cardiovascular applications. So with that warm introduction, I'll let Pierre get straight into it.
Thanks so much, David. Thank you again for having me. It's an absolute privilege and it's wonderful to be here. And I look forward to any and all excuses to come visit Los Angeles, because as fun as New York is, man, oh man, I would trade an arm and a leg for the weather that you guys get to have all the months of the year, particularly as a Florida boy who still is confused as to why it's cold in March and April. So thank you so much. I'm excited to talk with you all today. I'm going to go ahead and just pull up these slides here. But the most important thing I think is I would really love to have a conversation today. And I'm going to go through slides, but hopefully leave a good chunk of time at the end. And I want this to be informal because I think we are at this kind of interesting moment where artificial intelligence is one of these things we're seeing a lot in the news, and there's kind of a lot of changes that are maybe happening, or people are making lots of predictions about what the future looks like. But it's hard to decipher what matters and what doesn't. And everyone here is a busy clinician with lots of other things that they want to focus on so that they can, take good care of their patients and get through the rest of their day. So my goal is to present some of the work that we're doing here at NewYork-Presbyterian and Columbia, and use that as an opportunity to just spurn a lot of conversation about the whole spectrum, from, what are your experiences of places where machine learning is helpful or not helpful, to what are people's hopes and concerns about these new technologies that they come down the pipeline, to how much of this is hype versus reality, and how much of people's precious time and energy do they really need to spend on thinking about this. And so my hope is we can have just kind of an exciting and engaging conversation throughout the presentation and at the end, and just speak as colleagues about what is this new stuff and does it really matter or not. So these are my disclosures. And I wanted to start with a story of a patient I took care of when I was a fellow. This was a 60-year-old man who presented to a community hospital emergency department. He essentially had no past medical history. And 3 months prior, he had gone to the emergency department and he had had chest tightness and shortness of breath. And they ruled him out for an MI. They said, listen, everything looks fine, but just so you know, we heard a murmur on the physical exam, and so you should go see your primary care doctor about that, and he can decide, where to go from there. But you're not having a heart attack. It's totally fine to go home tonight. Life got busy. He never got to that primary care appointment. And then 3 months later, he had basically the same symptoms, chest tightness and shortness of breath. And he went back to that same emergency department. This time, though, he was in full-on respiratory distress, and he ended up getting intubated and sent to the ICU there. And they did an ultrasound the following morning, and they found severe aortic stenosis. And he was kind of immediately packed up and getting ready to be sent to us that evening. And by the time I got the call kind of in the middle of the night, he was in multi-organ failure and doing extremely poorly. And I worked on him all night. We cannulated him for ECMO. We put him on CPVH. We did all the things, but unfortunately, he died this week. This was someone who had no other past medical history. And if we had just known that he had severe AS, he probably could have gotten a TAVR or a SAVR as an outpatient, and he'd be alive today. And one of the things that really crystallized for that was it taught me you can't treat the patient you don't know about. I could be the best cardiologist anywhere, and if I don't know about these patients or they come too late in their disease course, there's really not much I can do. And so we are constantly faced with this challenge of trying to get the patient to the right diagnosis, the right treatment, and the right provider at the right time. And we can try to just work harder, but that's not going to be the phase shift that we need in order to really provide better care. And so we have to change the paradigm, and we need to do something that's going to make care faster, cheaper, more equitable, and more accurate than what we do today. And I don't think we can depend on clinical providers to just work harder to get there. And so I think we need technologies and systems that allow us to do that. So the question becomes, is artificial intelligence going to be part of that solution? So throughout this talk, I'm going to use the terms machine learning, deep learning, and artificial intelligence, and just know I'm going to be using them interchangeably. So I think there are specific places where machine learning or deep learning make a difference. So I think if you're looking at tabular data, so when I say tabular data, I mean the sort of things that are in the electronic health record, like age, laboratory values, ICD codes, machine learning is rarely better than traditional statistics. And that's because this data is already very well featured. We already know what an abnormal troponin is, and we know what a normal troponin is. We already know that you're more likely to develop cardiovascular disease as you get older, and so on and so forth. And so there are real problems where technology can help, and that can oftentimes do with the workflow. So we want to automate analyses, make insights fit into the workflows as they currently exist, right? So that may be calculating a risk score, automatically generating a plan associated with it, fill out the orders, and just notify me. So there are lots of digital health solutions that can exist in places where you're using that sort of data. But when we talk about kind of machine learning, I don't think as a methodology, it offers a lot more than traditional statistics and multivariable logistic regression. And we see this. There's tons of places where we already have clinical risk scores that are being underutilized, right? There's lots of patients out there where we should be calculating a CHA2DS2-VASc on them and making decisions based off of that, and it's not happening for a variety of reasons. So I think medical imaging is different. So all we've had to date when we're interpreting medical imaging is the human eye. And the visual cortex of the human brain is amazing at pattern recognition, but it's flawed. And if you need an example of that, just look at this optical illusion on the bottom right corner of the page. All of those lines are parallel to one another, those horizontal lines, but your brain is telling you that they're not. And it's just because the visual cortex is really good at picking up on certain patterns, but not as good as picking up at other patterns. And that's why we have all of these optical illusions. And on top of that, medical imaging has a huge amount of data that we're leaving on the table. One CAT scan is really the entire electronic health record for 500 patients. And traditional statistics is very poorly equipped to analyze this sort of data. There is no way to take a multivariable logistic regression and apply it to an electrocardiogram. The pooled cohorts equation is really fantastic, but it would be really nice if I could include in that the risk associated with someone's electrocardiogram, which there's no way to do so easily right now. So I think there are specific places where machine learning or deep learning can make a big difference. And it's really exciting to see some of the things that are happening in these domains. So this was a paper from 2019 out of China that was in JAMA Cardiology. So there are these imperceptible differences in the amount of oxygenated and deoxygenated blood in our faces when our heart beats. And so what they did is they took plethysmography or PPG, And they trained a model to look at PPG from someone's finger while also looking at videos of their faces. And then it was basically able to detect regular versus irregular heartbeats just looking at the videos of people's faces. So this was in a cardiology clinic, just in the waiting room, and they were able to detect with high sensitivity and specificity whether or not patients had regular versus irregular heart rhythms just using videos of their faces. So I don't see this as just a natural evolution of the way that we practice care. I think this is a genuine revolution, and the opportunities to rethink the ways that we engage with patients and the ways that we're able to provide care are really significant. So my bet is that artificial intelligence is going to fundamentally change how we order, acquire, and review medical imaging in the next 5 years. And what we're trying to do here at NYP is build a world-leading center that develops, validates, and deploys AI for early disease detection, particularly around cardiology. And my group, Cradle, the cardiovascular and radiologic deep learning environment, that's really our focus. And we're kind of a team of cardiologists, data scientists, data engineers, and clinical trial coordinators who've come together to try and make this happen. So I want to tell you a little bit about some of the initiatives that we've been up to for the last few years. So if you look at a lot of the AI in medicine papers today, they tell a pretty consistent story. So let's say you're trying to detect pneumonia from a chest X-ray using an AI algorithm. The way that these models will work is they will say, well, we had a human expert's interpretation of chest X-rays that had pneumonia and chest X-rays that didn't have pneumonia, and that was our gold standard. And the current state-of-the-art model is about 70% as accurate as a radiologist. And then we built a new model, and that new model was 80% as accurate as a human expert. And so, you know, we have a paper, and we've shown that we are doing better than the current state-of-the-art, and we're getting closer to human expertise in being able to detect some form of pathology from some sort of imaging study or the like. We flip this on its head. And we say there's a lot of really important clinical problems where we as clinical experts and cardiologists aren't able to do a very good job. So what if we made the gold standard a more expensive, more accurate downstream diagnostic test? And then we trained our model to learn from that downstream diagnostic test and made that the label it was learning from. And then could we actually exceed human expert or physician performance on tasks that we thought were really important? So the way this could work, right, is we start with all of these tests that are first line tests like EKGs and chest X-rays, which we know are a lot cheaper than echocardiograms or caths and cardiac MRIs and CCTAs. And we say, well, can we take these pieces of data, like EKGs and chest X-rays, these cheap diagnostic tests, and then could we learn from the patients who have both these cheaper tests and these more expensive tests like an echo, who does or doesn't have some sort of pathology from the echocardiogram? And then ultimately, could we potentially even determine who needs the more expensive or the more accurate diagnostic tests that are even more expensive than that? So an example for this is looking at valvular heart disease. So we know valvular heart disease is diagnosed with echocardiograms, and it's expensive to do an echocardiogram. My daughter just had a newborn echocardiogram, and I got a bill for $3,000. And I was kind of stunned to see that that was how much an echocardiogram costs in New York City. It's symptom driven. So oftentimes we're waiting until there's pretty significant pathology, right? We know lots of people out there with asymptomatic severe aortic stenosis. Yet we do 9 electrocardiograms for every 1 echocardiogram at NYP. So we have a huge number of people out there who have these cheaper diagnostic tests laying around. And we as cardiologists, we can't look at an electrocardiogram and detect valvular heart disease, but we asked ourselves, could an AI model do that? So we took all of the patients who had ECGs and echocardiograms, and we trained a model to say, well, this is what the electrocardiogram of someone with valvular heart disease looks like, and this is what the electrocardiogram of someone without valvular heart disease looks like. Can you tell the difference? So our goal was to develop a deep learning model, which could look at electrocardiographic waveforms and detect patients with left-sided moderate to severe valvular heart disease, specifically AS, AR, and MR, and a composite of any of the above 3 being present. And you need a lot of data for this, but this is what was kind of exciting about this work. So we took data from 4 of our hospitals, Allen, which is one of our community hospitals, Milstein, which is our flagship hospital here at Columbia, Choney adult patients, so all the adult patients seen at 18 who are 18 and above. So you can think of like all of those people who are getting like athletic clearance and the like. And then one of our other community hospitals, NYP Lawrence. Then we had to take all the people who had ECGs and echoes done within 1 year of one another. And we had to exclude almost half of the data. And the reason for this is we really didn't want the model to cheat. So if the model saw that someone had a paced electrocardiogram or a wandering baseline, it could very easily pick up, oh, well, someone with a pacemaker, well, that person probably has cardiac pathology. It's just much more likely. And it would basically be learning from these non-physiologic parameters. And we didn't want it to do that. And so it was really painful, but you have to throw away a big chunk of your data. And this is why it's so important to start with really large data sets. But then we had patients stratified to train, validation, test, and we had a holdout test site as well to try and detect AS, AR, or MR. So we ultimately built this retrospective model, and in our test set of 21,000 patients that the model had not seen, it had high accuracy in the detection of aortic stenosis, regurgitation, and mitral regurgitation, and an AUROC of 0.84 for a composite endpoint of any of the above three being present. So we were really excited about these results, but I think every person in this room has seen retrospective data that looks really great and is very convenient and fits exactly what the authors wanted to fit. And so we felt very nervous, to be honest, about these results because it was a very nice and convenient story. But I was constantly asking myself, is the model just cheating in some way? Is there some form of label leakage or something else that's going on as to why the model can do something I, as a human expert, cannot? And so we said, the only way to really know is we have to prospectively test this. And so we began our journey of saying, how are we going to be able to prospectively test these models? So this is right outside my office at the Department of Biomedical Informatics, a place that is steeped in IT and steeped in cutting-edge technological research. And yet this is still the way that we recruit for so many clinical trials, right? The elevator bank just has like an infinite number of papers that say, hey, are you 18? Have you never had an X-ray? Are you in good health? If so, we'll give you $20 if you come in. But this is a terrible way to run clinical trials for a number of reasons. One, it's extremely slow going to have patients come this way. It's very human resource intensive. And also, it really affects who are the patients you're recruiting, right? From an equity standpoint, there may be a lot of patients out there who need your help, but aren't going to be the sort of patients who, are reading English pamphlets that you have at your elevator banks in one of your departments. And so we said we need a new way to be able to acquire the data so that we can recruit patients and not only do so at scale, but also make sure we're doing so in a more equitable fashion than we previously have. So we created this real-time detection system. And so what this looks like is we have different vendors, including Philips, Syngo, GE, with different modalities, echocardiograms, electrocardiograms, catheters, catheterizations. And all of this data, within 15 to 30 minutes of it being generated, is automatically transferred to our research and analytics servers and then goes to our deep learning environment in the cloud. We use Microsoft Azure, but I've used them all, AWS and GCP and Azure, and they're basically all the same. But the idea being, as soon as clinical data is being generated, it's immediately being offloaded and transferred to an environment where we can analyze that data, and we can pre-process that data, and then ultimately we can run our AI models on the data. And then from there, we're able to analyze the data, run our models, and get outputs. And from those outputs, able to get back to either the clinicians who are taking care of those patients or to the patients themselves for clinical trial recruitment. And so this system is live. To date, basically every electrocardiogram across our 8 hospitals at New York-Presbyterian, within 15 minutes of the ECG being done, our model has been run on it. And what we essentially do is we just generate a list of high-risk patients that's sent to myself, my co-PI, our clinical trial coordinator twice a day. And then from there, we're able to chart review, figure out if those patients meet inclusion-exclusion criteria, and then reach out to their clinical team or the patient themselves for clinical trial recruitment. Now, another part of this is I really think we're in the early phases of deep learning being adopted in clinical practice. And with that in mind, I think one of the most important metrics is positive predictive value. And the reason for that is, like, I want to be able to go to my colleagues and say, listen, we ran this this model on your panel of patients, and 5 patients came up positive. And I want to be able to tell them the positive predictive value so that I can say, listen, with the positive predictive value being 20%, would you send all 5 of your patients for echocardiograms to find 1 patient with undiagnosed moderate to severe valvular heart disease? And I think we have to really understand the performance of these models in that way in order to be able to communicate with clinicians and build trust. The challenge here is, I told you we built a model on patients who have ECGs and echocardiograms, but then we want to test the model on people who just have electrocardiograms and maybe have undiagnosed valvular heart disease. So the challenge is, I don't know what the prevalence of undiagnosed valvular heart disease is in patients who just have ECGs. We also know they're probably a less sick cohort than people who have ECGs and echoes. So what we did is we actually modeled out the performance at varying levels of prevalence of the disease. And we said, our best guess is maybe there's a 2% prevalence. And if we just need to capture the top 20% of undiagnosed disease, we would have a positive predictive value of around 18%. And we felt, yeah, I would probably send 5 patients for an echo to find 1 new case of undiagnosed valvular heart disease. And that's what made us feel comfortable enough to say we can go ahead and proceed with a trial. Because what we didn't want to do was build a model where you would have to bring in 100 patients for an echocardiogram to find 1 person with some undiagnosed disease, because we think that would be inappropriate. But we don't know what, we're still left with the challenge of we don't know what the prevalence is. So we have to take our best guess and then take that leap of faith and say, well, let's see how our model actually performs in the real world. So I can't share the trial results as they currently exist today, but I will say that we've recruited around 60 to 70 patients so far, and we're quite excited with the results. And we have found that our model can accurately detect valvular heart disease and then structural heart disease at large. But one of the things we learned pretty early on when we were generating this trial is our model, which was just trained to look for valvular heart disease, was picking up a lot of other pathologies. We picked up patients with undiagnosed cardiac amyloidosis, undiagnosed pericardial effusions, reduced ejection fractions, a couple of patients with atrial fibrillation. And we started to realize that there's probably a signal to noise issue. And we had set up the trial to have a primary endpoint of detecting valvular heart disease, and then a secondary endpoint of looking at an expanded label of structural heart disease. And so it'll be interesting to see with the final study results how it performs in both of those. But one of the things I think I learned from this is the real question to ask is, of all the patients with an ECG and no echocardiogram, who needs an echocardiogram? And can you turn ECG into a reflex test for echocardiogram? And so where we're at right now is we're running this 200-patient pilot trial for adults who are above the age of 60, who have an electrocardiogram in our system, but no echocardiogram. They can't have life-limiting cancer. They can't be in the ICU. They can't have an echocardiogram at an outside health system done within the last 5 years. And they can't have dementia. So really people where you could imagine doing a valvular intervention on them to improve their quality of life. And we're essentially looking at all of the electrocardiograms as they're happening in real time in the health system, trying to find patients who are recruitable based off of these criteria. And we can talk more about our findings, but it's really interesting to try and do this learning health system work, because we have a bunch of patients who have scores of 0.8 and above, but a huge number of them, they either are coming to us for referrals from other places for valvular intervention. So the model is like working amazingly well for these people who have high scores, but none of them are recruitable by the trial standards because someone already knew they had valvular heart disease, but the AI model didn't know that because they didn't have an echocardiogram in our system. Or there's a huge number of people who it diagnoses, but they have dementia or something else, because we know these are progressive diseases. And so those patients wouldn't be appropriate for clinical intervention. So it's very interesting to kind of see some of the challenges. But our primary endpoint is moderate to severe MR, AS, or AR. And then our structural heart disease secondary endpoint that you can see here, really all the things you would want to know about a patient if they didn't have an echocardiogram, right? So ejection fraction less than 45%, severe LVH, moderate to severe valvular heart disease, including right-sided valvular heart disease, RV systolic dysfunction, moderate to large pericardial effusion, or pulmonary hypertension. If I told you a patient had one of these things and didn't have echocardiogram, everyone would agree, what's the next step? Get an echocardiogram on them. So one of the things we learned pretty early on is you can spend years just trying to build something in Epic to deliver these results. And we didn't want to wait for that because we had no idea if this model was actually going to work. So we built fast. And so what we have is these EKGs are batched twice daily. The model is run on them. And then we just get an Excel spreadsheet sent to us via email twice a day. You can see it says, hey, here's the noontime predictions. There's 1,800 of them. And it basically will tell us, where is the patient right now? What's the prediction score? Do they have an echocardiogram or not? And then our clinical trial coordinator can then quickly do a chart review and say, okay, well, is this a patient who is or isn't a candidate for the trial? And then reach out to their team and say, could we recruit this patient? And then reach out to the patient themselves. And this is just one of the things I've learned from experience. Just, build minimum viable products. It can be so challenging and so difficult to build something within the EHR. And then you're also asking yourself, is it that your technology works, or is it that your intervention and the way that you choose to display the information that works? And we really wanted to isolate, this first-in-man validation of this AI model. Can it do something I, as a cardiologist, can't, which is accurately detect valvular and structural heart disease, rather than does an intervention using this specific BPA and this specific, clinician population change clinical practices? Because I think those are two separate and equally important questions. And so what we've done is we've now expanded ValveNet, our original model, to something called EchoNext, where we're building a model that's actually trained not only on valvular heart disease, but also all of these structural heart disease labels. And the goal here is to cross-validate at Columbia and Cornell. So if I build a model at Columbia and then test it at Cornell, will it perform equally well, where there's a very different patient population? It's basically flipped as far as the payer mix goes. The same thing is true the other way. So can we build a model at Cornell and then test it at Columbia, and will we get equal performance? What about our academic hospitals and tertiary care centers versus our community hospitals? And then what about our different racial and ethnic groups and payer mixes? Are we actually building a model that's equitable? And so, in order to do this, we had to create a cardiovascular data mart. And this is the data mart that we've spent the last few years building. So it's almost 12 million electrocardiograms and 1.5 million echocardiograms from 8 hospitals, I think 5 different echo labs. Some use Singo, some use Accelera, almost all of them use Philips machines. And we sanitize this data. It's amazing the crazy stuff you'll see. A totally normal EKG, but then the top box will have a QTC of 5,000 or a PR interval of 32,000. There's also, when you start looking at data at this scale, there's all sorts of crazy things that happen. And then tokenizing it, so actually taking all of that kind of unstructured and semi-structured things where someone may type out the patient has, mild to moderate eccentric aortic regurgitation, and turning that into something that's tokenized and fully structured, and then validating all of these phenotypes that we created, having clinicians at different reading sites do it, and then ultimately harmonizing it. So we have a single table that has echocardiographic and electrocardiographic data for people, regardless of which hospital it is, basically equalized, so that we can look at it from one place and say, yeah, we really can build models and test these models across the health system and the health enterprise. And these are hospitals that really have nothing to do with one another. Brooklyn Methodist and NYP Queens, none of the people who practice at Columbia or practice at Cornell are practicing there. So it's an entirely different practice group with different practice patterns. And so we think it's really important to be able to bring that diversity into the data set and say, well, is this something that really works? So it's really exciting to see. These are the results of all the individual models. So like, how well can it do on RV systolic dysfunction, pericardial effusion, so on and so forth. The one thing I'll point out is if you asked a cardiologist, what are 2 pathologies you could pick up from electrocardiogram, the 2 they would probably point to are pericardial effusion and LV hypertrophy. And yet those are the two of the worst performing models in our group. And it's really interesting that those are the ones that we feel like we have criteria for and we can make a diagnosis for. But none of us would say, yeah, I can say that someone has a reduced ejection fraction or significant RV systolic dysfunction from an EKG. And yet the model does quite a bit better on those labels than it does on the two that we comfortably call. So again, it just goes to checking our assumptions of what we can and can't use electrocardiograms to detect. So like my real hope here is someone who's at a community hospital who's just getting evaluated for a knee replacement and gets just routine preoperative work, it can then be detected and say, hey, I know you need a knee replacement, but it turns out AI told us you also need to see a cardiologist. And being able to find and take care of these patients before something significant happens and provide equal care, whether you're at the big academic tertiary center or the community hospital, would be a real dream of mine from all of this sort of work. I'll tell you a little bit about one of our other projects. So cardiac amyloidosis, rare cause of heart failure, often missed until too late to treat. At Columbia, we have Matt Maurer and Andrew Einstein and a number of people who are experts in cardiac amyloidosis. And we have this paper where we looked at the number of PYP scans we'd done. And over the course of 4 years, we had doubled the number of PYP scans we had done, but the rate of positivity had remained the same. And so we thought this was smoking gun evidence that there are many more patients out there undiagnosed with cardiac amyloidosis than we originally thought. And we had over 2,000 patients who are above the age of 60 who had an echo in the last 3 years with very high-risk features for cardiac amyloidosis and no PYP scan. And so we said, could we build a model that looked at ECGs and echocardiograms in order to accurately detect cardiac amyloidosis? And we were able to do so. And so we had a model that looked for cardiac amyloidosis and had good performance in the detection, both with just ECG alone and then ECG plus echocardiogram. And now I think there's really been a number of places, ourselves, David Oyang from like Cedars-Sinai and Stanford have shown this. The Mayo Clinic has also shown this. There's really been a number of people. And in fact, actually, a UK-based company just got FDA breakthrough approval this week for detection of cardiac amyloidosis from echocardiogram. So this is one of these things that really feels like it's kind of coming down the pipeline and has been replicated in multiple places. So we wanted to do the same thing that we did with ValveNet and EchoNext. And so we are embarking on a 100-person trial for the detection of cardiac amyloidosis. And because the equity component, particularly in our patient population, which is predominantly Black and Caribbean Hispanic, we want to make sure half the patients we recruit are Black and Caribbean Hispanic for the trial. And one of the things that was really interesting when we were embarking on starting this trial was Matt Maurer, who's a friend and mentor to me. He said, listen, I know this disease should have a preponderance in Black patients and Caribbean Hispanic patients, particularly with the VAL133 mutation. But my clinic is all these white people from Jersey and upstate New York. What's going on? I said, well, that is very interesting. Let me just look at some of the data. And so what it is, I looked at the relative proportion of white, Black, and Hispanic patients who just showed up at Columbia. So it's about 46% white, 17% Black, 38% Hispanic. Okay, what about the people who get an ECG? Very similar, 43% white, and so on and so forth. Echo starts to get a little more white, a more expensive test, more advanced test. And then PYP scans was overwhelmingly white. So the people who we refer for advanced cardiac diagnostics do not look like the people who show up at our doorstep. And we said, is there bias in current referral patterns? And could AI actually potentially help correct this bias? So we said, is there a diagnostic gray zone of patients who could be referred for PYP scan but currently aren't? So the Mayo Clinic have this score called the TCAS. And it's a very simple risk score. It looks at their age, male, the wall thicknesses, their EF, and whether or not they have hypertension. They say if they've got a score greater than or equal to 6, that has pretty good sensitivity and specificity for cardiac amyloidosis. You should think about referring this patient for PYP scan. Now, this is literally tens of thousands of patients in our health system, right? And we can't send all of these patients for a PYP scan, which involves radiation. Normally, we do a few hundred PYP scans at Columbia per year. overload the system. And this is still pretty insensitive, all things considered. So we asked ourselves, could we start with people who have a TCAS greater than or equal to 6, and then further risk stratify using our AI model? And then could we make sure that we have a model that actually performs equally well on various race and ethnicities? And so this is some great work led by Tony, Sneha, and Katie. Tony and Katie are two of the PhD students I work with, and Sneha is a rock star cardiology fellow at Stanford currently. So the first thing is we looked at people who had PYP scans and a TCAS greater than or equal to 6. And we saw that the model did a really good job of risk stratifying those people. So even amongst all the people who have a TCAS greater than or equal to 6, it looks at that group and it can still do a very good job of further stratifying who does and doesn't have cardiac amyloidosis. So then we looked at all the people in our health system who had a TCAS greater than or equal to 6 and didn't have a PYP scan. And we asked the model, look at their ECG and echocardiogram, and then tell us, do you think that they have cardiac amyloidosis or not? And lo and behold, the percent of people by race and ethnicity that it thought were positive for cardiac amyloidosis was very, very similar. So then if you just took these people that the model called positive and you referred them for PYP scan, you would go from our current schema, where 80% of the people referred for PYP scan are white, to this, where 54% of the people are white, 16% are Black, and 31% are Hispanic. So you can really profoundly change referral patterns for PYP scanning, and potentially the distribution of race and ethnicity for who gets diagnosed for this disease using AI. And we think that's a really profound and useful place where it can actually help correct bias rather than contribute to bias, which I think is one of those things everyone is worried about with AI, and right and correctly so. One of our other projects looks at chest X-rays. So we all know cardiomegaly is a useless diagnosis, right? It never leads to a clear next step of, should I get an echo on this patient or I shouldn't? The thing is, chest X-rays are the most common diagnostic image of the heart in the world. And so at the same time, most people only get diagnosed with heart failure when they become symptomatic, right? Stage C heart failure usually is when people are diagnosed. But we know that patients undergo cardiac remodeling with stage B heart failure before then. So we asked ourselves, could you detect these changes with a test as cheap and prevalent as chest X-ray? And could we kind of move beyond this diagnosis of cardiomegaly to something like severe left ventricular hypertrophy and dilated left ventricle, so that we could actually use chest X-rays to find patients with undiagnosed heart failure, and particularly cardiac remodeling in stage B heart failure, and get them to echocardiograms and advanced care sooner. So this was great work led by Shreyas and Victor, two of the PhD students I work with. And we built a model to detect severe left ventricular hypertrophy and dilated left ventricle from chest X-ray. This was built on 70,000 chest X-ray echo pairs here at Columbia, and then validated on another 10,000 chest X-ray echo pairs from Stanford University. And then we had 15 radiologists from around the country go head to head against the AI model for 400 images. So they read 400 images, and we told them, we want you to read the way that you're expert. So read for cardiomegaly, but understand we're trying to find real cardiac pathology here. And the AI model is going to be looking for LVH and dilated left ventricle. And we want you to try and say, yeah, this is someone who I think has cardiac pathology. And half the images were from Columbia and half the images were from Stanford. And these were academic and community doctors. Everyone was board certified. We had chest fellows, chest attendings, and general attendings from around the country. And the AI model outperformed all 15 radiologists in detecting cardiac pathology. And so this is really the first time ever that an AI model has been shown to exceed radiologist performance in cardiac pathology. The best models to date are looking at cardiomegaly, and they're getting 90% as accurate as the radiologist at a label that we all know is not very helpful. And so we're really excited about this, because it's one of these things of, if we uncouple ourselves from the reading of a radiologist, or what we kind of use as our current clinical paradigm, perhaps we can find pathology in a more accurate way than experts are currently doing so. We'll skip this. This is just showing we saw similar performance at both Columbia and Stanford with our data set. So I've shown you a lot of things where AI can help us do things that are not currently possible, but can it just help with some of the dumb stuff? Like, I don't know a single cardiologist who doesn't have to just deal with some really dumb and annoying things as part of their daily clinical practice. So, I mean, here's just a perfect example, right? Where we're looking at the PW across an apical four-chamber in the mitral valve, and I've got to find the right wave that I want to measure, and then I've got to trace out the envelope with my mouse. And it's just like when you're trying to like sign your signature with a mouse, and it looks terrible in comparison to writing it with your hand. It's pretty sloppy. This is one of these things. So we've asked ourselves, well, can't AI help us with this? And so this is actually one of the technologies we're building right now is automating CW and PW segmentation. And the dream here is as soon as you open up a study, all CW and PW segmentation that you need to do for that study, whether it's the aortic valve VTI or just the peak velocity, the E prime and the A prime, the tissue Doppler, all of it is just done for you and measured. And so this is our project called EchoStar. And so the goal here is to basically complete all CW and PW segmentation for clinicians before they open the study. And the two things we really want to see is, one, can clinicians tell the difference between an AI model segmentation and a colleague segmentation? So Columbia is kind of unique. Our stenographers don't do any measurements. They just capture pictures, and all of the measurements for studies are done by either a cardiology fellow or a cardiology attending. And so we have these super high quality labels for like all 400,000 of our echoes. And so we want to see, can they tell the difference between if it was an AI model that made the measurement or a clinician who made the measurement? And then does this also save them time? So this seems like a nice thing to have, but will it actually save any meaningful amount of time if you just open up the study and all the CW and PW segmentation is done? Can people read more echoes in the same amount of time if we do this? And so this is one of the studies that we've been working on for the last many months. Lastly, I just want to have this kind of open invitation. We have workshops to try and make this work available to people. So I have a tutorial out there called Intro ECG, which walks people through soup to nuts, everything you have to do for deep learning on electrocardiograms. It's a freely available library. I run workshops on it at the American Medical Informatics Association and ACC. We have lots of programming, thanks to David, who's had a kind of incredible leadership through the Innovation Council for ACC, of like really trying to have dialogues about this sort of work and where are we heading with digital health at large, as well as kind of AI specifically. And there will be similar things happening at TCT this coming year. And so, it's not too far from you guys in San Francisco. And we have this group called Train Cardio, where called the Task Force for Research Advancement in Artificial Intelligence Cardiology. Really, this is just a collective of investigators who do AI and cardiology work, where we say, how do we move this field forward? How can we establish standards? How can we make it easier to validate work across multiple sites? And how can we find like major technical challenges that we're better off tackling together rather than trying to recreate the wheel from scratch at every single place? I'll just briefly show one of the projects that came out of our collaborative with Train Cardio. So, the pooled cohorts equation is one of the cornerstones of cardiology, and answering this question of will a statin save you from a heart attack or stroke is one of the key things we all do as cardiologists. So we know pooled cohorts equation is great, but it would be lovely if I could also include the electrocardiogram in someone's risk profile, but there's no easy way to do this. But this is a great problem for AI. It's called dimensionality reduction. Take something like an image and make it fit within an equation or logistic regression model or quantify tabular data. And so we built a machine learning model to assess 5- and 10-year cardiovascular mortality. And we actually tested this on over 1 million ECGs from Stanford, Cedars-Sinai, and Columbia. And it not only works across sites, but also across vendors. Stanford uses Philips TraceMaster. We use GE Muse. And we were able to solve it so that these models are stable, not only across sites where we know the ordering patterns are going to be different and the patient populations are going to be different, but also the vendor technologies are different. And what's really interesting from this is if you look at people's pooled cohorts equation, so this is patients who had 10-year cardiovascular disease risk plotted out. you've got this group of people who are low risk by pooled cohorts equation. And then amongst them, SEER, which is the name we gave for this AI ECG score, there are people where they're low risk by pooled cohorts, but then high risk by SEER. And so then they have a 10-year cardiovascular disease risk of 9.7%. And so these people should be on a statin, but currently aren't. And then the same thing is true amongst this moderate risk cohort. There's a number of people who shouldn't be on a statin, but currently are. And so this is really interesting because we see how EKG could just become another one of those modifiable risk factors, the same way, you know, CRP is and all the other things that we've added as modifiable risk factors to the pooled cohort equation over the years. And really the exciting thing to me is we're starting to see some validations that you can accurately use models like this from the wrist using an Apple Watch and other technologies. And so this is something that affects 30 million Americans. And a number of people have access now to, whether it's an Apple Watch or a Fitbit, some way to easily get either a 1-lead electrocardiogram or a 12-lead electrocardiogram in their clinic's office. And so we could really see this as one of the first ways where AI becomes fitted as a modifiable risk factor, as you know, part of one of the foundational things we do in cardiology. So with that, a huge thank you again to David and the rest of you for having me today. This is our group, Cradle, kind of a fantastic and phenomenal group. A big thank you to Tim Poderuca and Chris Haggerty. These two guys right here are my co-PIs and co-captains in all the work that we do. A big thank you to kind of everyone at NewYork-Presbyterian and Columbia that have supported this work today, including Alan Schwartz and Nick Homa, our chief and vice chief. And then a huge thank you to our team who kind of continue to do incredible work every day and inspire me in the opportunities that we have. So thank you all again. It's been an absolute pleasure to get to chat with all of you.
Thank you so much, Pierre, for that wonderful overview of all the work that you've been doing, not only at Columbia, but for the field and across the country with all the other partnering institutions that you've been working with. I guess we'll open it up for Q&A. I think we have about 10 minutes, and I know that Dr. Elias wanted this to be sort of an informal Q&A. I'll just start with one quick question. So I know that there's a lot, you mentioned that the humans are good at picking up pattern recognition and EKGs, and that's sort of like the history upon which, you know, we've seen one, done one, taught one to future generations. Somewhere along the way, Q waves were associated with MI, et cetera. Is there anything going on in sort of the reverse in that these AI models can have some form of explainability, being like, aha, this is what I'm looking at, and maybe being able to train and teach sort of some new pattern recognition to the human eye?
Yeah, I think it's a great question, David. I think it remains one of the holy grails for this field of like, I mean, at the end of the day, like we all know, like it's radiologists, they like build CT scanners, and then, you know, after a while they're like, hey, I keep seeing this pattern on a CT scan. Let's like give it a name and then say like, let's look for this. And that's, you know, consistent with pathology, right? So pattern recognition has a long history in medicine for sure. I think the name we give for kind of like trying to explain what the AI model is looking at is called saliency mapping, or is at large. And I think it's all BS right now. You know, when we write these papers, they're like, oh, show us the saliency maps and like, you know, explain to us like what you think this is going on and how does this correlate with pathology? And I think it's all bogus, and most of us in the field do as well. It's just the techniques for trying to explain AI are still really crummy, and it's just very, very hard to try to transfer what it is that the AI model is looking at into something that we want. And I'll actually just show a really quick 2 slides that I think really elucidate this. So this is some work from colleagues at NYU at the Cron Institute. So this was a paper in Nature Medicine. So what they did is they built an AI model that was detecting AFib versus normal sinus rhythm from EKG. And then this model was 100% confident that this was AFib looking at this waveform. And then they added this smooth perturbation. So they just added this noise to it. And it went from being 100% confident that it was AFib to 100% confident it was normal sinus rhythm. And then they did the same thing. They took normal sinus rhythm, and then all they did is they just added this little bit of noise here, and they went from being 100% confident that it was normal sinus rhythm to 100% confident it was AFib. What we are using as our gestalt, right? The fact that we're like, oh, there's a P wave and then QRS complexes, and I'm looking at the regularity of the RR interval. We can't take our mental model of how we've interpreted this information to date and just apply it to the AI model and say, well, it's probably looking at some variation of the P waves or the QRS complex or something like that. It has no concept of any of those things, and it frankly doesn't care about the mental models we've created to date. So I think it's really hard from an explainability standpoint to get there. Now, does that mean we shouldn't use like these technologies? I personally, like at the end of the day, do I actually understand how like photospectroscopy works? Like when someone like takes blood from a patient, puts it into a literal black box, and then says, hey, the troponin value is this. No, I don't know the basic science of it. Yes, there is a physiologic basis for what troponin levels are, but at the end of the day, I have to trust the medical system to say, big number bad, little number good. And this has been validated across a number of patients in a number of settings. And when used appropriately, that the test gets you to who does or doesn't need further intervention. And so I think the same thing is true. I don't think we're going to get to full explainability with AI, but we have to treat it like any other sort of therapeutic. And we have to do prospective clinical trials, validate these technologies, and be humble about the idea that like we don't fully understand what they're basing their technologies for. But I would love it if it got to a point where we could actually explain something from it, teach that to clinicians, they use that prospectively, and then they're able to improve their capacity to like diagnose valvular heart disease from EKGs. But I don't think we're there.
All right, thanks for that. I guess we can leave it open for questions for any of the people on the Zoom call. Just unmute yourself and ask away.
I like how there's an entire Zoom group that's EP med students.
They are the most important ones. Well, I guess if nobody else has any questions, then we can give everyone back, I guess, 5 minutes of their time this afternoon. And just wanted to thank you again for taking time out of your. Oh, Jeff has a question.
I just wanted to say thank you so much for this fantastic talk, and I'm sending you a chat because I'm going to invite you to do another talk for me.
Thank you very much, Carol. I appreciate that. It's very kind of you.
Hi, Pierre. Hi, my name is Jeff. I'm one of the assistant professors here at UCLA in our advanced heart failure group, also part of our sports cardiology program. Your talk was fantastic. Thank you so much. In at least with regards to our work in sports cardiology, screening is a big and hot topic, and how we use ECGs in screening of athletes, the appropriate role. So your talk really helped, got me thinking about how we're going to be using AI in the future to essentially screen for things like valvular heart disease. I think the issue in sports cardiology is the consequences of the false positives. So I think you mentioned maybe a goal of doing 5 echo. If AI can help us get to the point where we can do 5 echoes and diagnose one person with valvular heart disease for every 5 echoes, I think that it sounds great. I guess the cost of the other 4 echoes and also things, unintended consequences of that, doing extra testing when it may not necessarily be indicated. I guess I'm curious, we're entering this entire new world, this new paradigm of how we're going to be diagnosing heart disease. Just curious about your thoughts about how you view that problem of integrating this technology.
It's such a good question. And I think, again, it comes back down to admitting humility. So I think sports cardiology is a perfect example of one of these areas where you can cause a lot of distress and unintended consequences being like, well, let's just be safe, right? Well, okay, you've got LVH and I don't know if it's athletic heart or not. So like, how about you just like, don't practice when like this is someone's entire life and, they run the risk of like, losing their scholarship or their livelihood. I remember we took, we're right across the street from the Armory, the big field and track and field location. And I don't know if you guys know, like a couple of years ago, there was someone who dropped and had VT, and then they were admitted here, and we had a lot of conversations about what to do. But like when you're meeting an athlete and you're saying like, oh, we're gonna put a device in you and this is going to end your career, people fight back. So I think there's a lot of unintended consequences that exist. So I think two things. One, we don't like, this is deep learning version 1.0, and we don't want to build models where it's like the doctor is, we want to find undiagnosed disease. We don't want to build models where someone is like thinking about getting an echo on a patient and we dissuade them from doing it, right? So like, we don't want to build like something where like the insurance company's like, well, the AI model said they don't have valvular heart disease or something like that, so
Right.
don't get an echo, right? And then like they have to get like some extra layer. We don't want to stop clinicians from doing testing that they currently do. Like that's just not appropriate. Like AI models are like, we're still learning all of this, and like for these like early explorations, let's not try to stop people from getting diagnostic testing, because I would feel horrible about that if the model was getting those things wrong. The second thing is there's this really interesting thing called the Thornberry hierarchy. This came out back in the 90s, and this is like this hierarchy for like how do you move the needle forward for like creating new technologies, particularly around diagnostic imaging, right? And so the idea is first you just have to prove technical efficacy. So like if we think about like mammography, right? Does it actually like effectively penetrate breast tissue? Two, diagnostic efficacy, using some sort of gold standard like pathology. Can mammography like accurately diagnose breast cancerous lesions? By implementing mammography, do we increase the total number of mammograms that are diagnosed? Do we, or the total number of breast cancers diagnosed? Does that actually, are those breast cancers that are treatable, and do we change it? Does that actually lead to better 5-year survival? Is that actually an effective use of society's resources? We're still down here for AI, right? And I think that's the thing that everyone just has to like, that's doing this sort of work has to acknowledge and say, I would love to answer these questions, but I'm still freaking out and like losing sleep at night of like, does this AI model actually do something I can't do? Or am I just being an idiot and missing something and it's just cheating in some really obvious way? And so I think we have to answer these questions and then work our, as things prove themselves to, do these first things, work our way up the chain. And so I think we're still a long way away from these. And I think it's just, the people doing this research having the humility to say, there's a lot of really important things we have to figure out before I think it's still a long way before US Preventative Service Task Force has anything related to AI in the guidelines with like an A or B next to it.
Thanks, Pierre. And one follow-up question is, for a lot of your work, you're using the ECG as kind of the input variable and trying to extract meaning from millions and millions of ECGs. This variable is, although we use it routinely, it is pretty sensitive to loading conditions, like whether it is, and if you can't see the state that the patient's in when the ECG is obtained, and you're kind of just anonymizing these ECGs that you're interpreting, how do you factor that into your ultimate analysis? Because even things like changes in the STT segments, height of the R waves, really dependent on blood pressure, and stress of the patient in that given moment. And especially when you can't really extract which features the models are actually picking up and associating with the outcome of interest. How does that get factored into your use of the ECG itself as a main variable?
So great question. Limit the ways that it can cheat. So you have to think about like, what are all the forms of non-physiologic data that it could be capturing that are dangerous, right? So that's why we take out ventricularly paced ECGs, poor diagnostic quality ECGs, all of that. I think have simple inputs, right, to try and minimize the ways that there can be label leakage and cheating, and then have a lot of data, right? Because if you have lots and lots of data, it can't, you're going to have the SD segment in every possible place, and then the model can't effectively perform well across the whole spectrum of patients you're providing it. And then understand all you've done is proven that your model works well for this patient population that I put the data set in at this location. And like, don't presume you can take a model that was built on inpatients and automatically apply it to outpatients, or you built a model at Columbia and it's automatically going to work at UCLA. So again, it's like having humility about what have you proven thus far, and like what can you actually say. A perfect example is like our ValveNet model. It just looks at age, sex, and the ECG waveform. And then I was noticing like all the time, you guys know how like when a patient's a John Doe, they come in there like unknown Virginia or like unknown California or whatever. And like all the time, these patients were like at the top of the list. And I was like, those patients are sick, right? Like a lot of them are in the unit, like they're unconscious and things like that. So I could see like those are really sick people, but it's just happening over and over again. And then I realized what was happening is like when you're like an unknown, like California, we don't know your age. And so then it makes the date of birth January 1st, 1900. So then the AI model was like, oh my God, they're 123 years old. They must have valvular disease, right? All the 123-year-olds must have valvular disease. So even with the small amount of data that we gave it, it was finding this thing, and stuff, and having this kind of unintended consequence. And so there's always a way for these models to cheat or to give you results that aren't what you expect them to be. And you have to just be like very conscientious about it.
Have you tried different lead locations to improve EKG models?
Different lead locations? Is that what you asked, Henry?
Why use the 12 lead? Maybe if you spread out the EKGs on the left and the right, and your machine might be able to detect even more pathologies.
So it's a great thought, right? So I think one problem is you need lots of data, and so you're limited with what are the ways that data is currently captured. And then the other thing is you want to build a model that can work in routine clinical practice. And so, if people aren't regularly getting right-sided leads or posterior leads, it's hard to build a model that can then be used in those ways. But yeah, I think there's probably more data that exists out there. Then we've also looked at the opposite. A lot of these models work like you'll get like 98, 95% of the way using just a single lead. You can just get away with like lead 1 or lead 2, and it'll work almost as well as if you had all of the leads. And so that's pretty interesting as well, and kind of a surprising result. And again, you have to like be careful. Like if we were building an AS only model has an AURC of 0.82 with just age. And then with the waveform, it's 0.89. But then when we're looking at mitral regurgitation or aortic regurgitation, a logistic regression model of just the tabular variables has like a very poor AURC of like 0.5. So you have to really prove to yourself, like, is it the electrocardiographic waveform that's driving insights here? And on top of that, like what part of the data that I'm providing it actually really matters. And so we have these things called like ablation experiments where you just provided small parts of the full data set, and then you see what happens. So, if you give it 3 seconds instead of 10 seconds, if you give it 1 lead instead of 12 leads, how well does it do? And it's surprisingly robust in a number of those sort of circumstances.
Thank you. It's great.
Hey, I have a question. This is Tim Cannon, one of the other assistant professors. I found it interesting that you mentioned like insurance companies and denying care, because that's one of the first places that my mind went. And I have no doubt that insurance companies are looking into this because they already have algorithms that they use to, automatically reject our requests for echoes or cardiac MRIs or whatever it is. And I mean, this has to be a gold mine for them in terms of using this to deny care or to in their mind more accurately tailor their payments.
Yeah, all of this, all the generative AI stuff just in general right now is kind of scary, let alone the like predictive AI stuff. The fact of the matter though is like for the last like 20 years, we know that we know the insurance people have had like automated algorithms to just deny our care and make our lives worse. And we haven't had a counterpoint. But now, like, I think every single person in this room would feel pretty darn comfortable going to ChatGPT and being like, please write me a prior auth letter. And so my hope is that it'll actually tip things back in our favor, and like we can kind of weaponize like, stop denying my care and the like. So my hope is like, they're definitely going to be getting stuff, but now, you know, at least for some of these things, I think it's like anyone can start to build stuff that's useful. And so actually what I'm really hoping for is like someone in this room goes like and gets an R01 on like generative AI, being like, hey, how do I like, you know, how do I make my life not so terrible, and like, you know, make insurance companies have to like provide appropriate care for patients and get through all of this sort of stuff. So that's at least my take on this one aspect. You guys know like ChatGPT is going to be an Epic pretty soon. So ChatGPT will be an Epic probably sometime in the next 3 to 6 months. And there's 2 places they're putting it. I forgot one of them, but the other one will be an auto replying to patients. So it will look at like the conversation or the question of the patient, and it'll auto draft a response to the patient for you, and you can choose whether or not you accept it. So like that actually feels like a quality of life improvement, right? There's like a lot of stuff where, you know, you're like, hey, this is really routine and things like that, and ChatGPT. Now we absolutely know there's that one guy in like each of our departments, right, who's just going to be like, yes, and then just like, you know, like just like highlight everything and be like, whatever ChatGPT says, like, yes, accept, right? And then patients are going to be like, you told me I have cancer, I don't understand, you're a cardiologist, what happened? So someone's, there's going to very quickly, I'm sure, be an email of this is why we can't have nice things. But that being said, like, I think the more we like understand these technologies, and the more people kind of like step up and say, I know how I want to use this. I'm gonna take charge of this, and I want to build something that's going to make our lives better. The more that can be the focus of the conversation, and not like insurance denying our claims with like greater expediency.
That is so interesting, Pierre. And while the logistical side of me says, oh my God, that'll make my life so much easier if ChatGPT can craft these responses, the logical side of me says, ChatGPT makes stuff up, and that's really not good.
Yeah. So yeah, that's a whole other conversation. I'm a vision guy and not a language guy, and it's really funny. Like the faculty member on the other side of my wall, she's done language models for like 20 years, and like is like one of the like world leading experts in it and stuff. And I was just like, yeah, it's all natural language processing. It's kind of boring. And like, you know, look at this. It's like now it's like, you know,
natural language. That's the hardest thing, is natural language processing. Sorry.
Yeah. No, absolutely. And we have a lot to learn about all of these technologies. They do confabulate, right? They do generate new things, but there's a lot that people like who just are experiencing ChatGPT don't know. So like, as an example, Matt Lundgren, who maybe some of you know, who's a Stanford interventional radiologist, great guy who I've worked with for years. He's now the CMIO at Nuance, and he's in charge of a lot of the ChatGPT stuff for Microsoft. And he and I have been talking a lot. But you're going to create you're going to create UCLA GPT, right? And so like, if you guys are actually going to use GPT for stuff, what you would probably do is you would just train it on a corpus of knowledge that are just the clinical notes from UCLA. And so then it's not looking at everything. It's basically going to be like, hey, the responses I can provide are only specific to what's like true of UCLA. And then you can probably even finer tune it of like, if I'm giving a patient-specific response, that patient-specific response can basically only pull from like notes and information about the patient and things like that. And so, yes, it still requires physician supervision.
That's the important thing.
Yeah. And by the way, none of these AI companies don't want physician supervision. Like they all want.
They say that, but do they really? Like, what technology has ever
really,
come
Carol,
out?
They want us to be the litigation lightning rod, right? Like that's what it is. Like it's like, yeah, like the market doesn't care about us.
No, not at all. Yeah.
Yeah, but at the end of the day, like they don't want, like they they have big juicy pockets, and like they do not want to like go down for like a huge class action medical lawsuit, right? And so
So-
they want everything to be a Schedule II device, something that's
Yeah,
like,
and
you know,
the-
provides suggestions to physicians and stuff like that. They want physicians in the loop. And so we probably will start to play just more of a supervisory role of like, check, check, check. Like, you know, everyone's going to now have like, you know, 15 mid-level providers or whatever, which, you know, there's a wide spectrum of like how many extenders people have and things like that. And I think we'll all just start to play more of an extension role. I think that'll just become part of the job.
That's fantastic. Pierre, I could talk about this stuff with you forever. I'm mostly concerned about the guardrails that don't exist and that the genie that's already out of the bottle. And we have to figure out how to make it safe and equitable and make sense.
Yeah. I'm sure we'll chat more about it.
Thank you again. This is such a fantastic talk. And did you get my chat?
I did.
I'm
I see it
inviting
here.
you. Consider yourself invited.
Well, thank you. I look forward to it.
All right, I'm sure we could keep Pierre here all day, but we're about 15 minutes after the hour, so I'm gonna release him so he can go back to learning more stuff from our EKGs and medical health records. So I want to thank you again, and for everyone else who stayed on the call for the extra time, and hope to have you back sometime. Come to LA anytime.
Thanks so much, David. Thank you all. Have a great day.
Take care.